Okay, so we're up to 24.6 on kidneys. So make sure you understand the anatomy of the kidney. We're going to talk more about the physiology now. Okay, so renal physiology, and this is what we're going to talk about in the next lab. Those of you that have the Monday lab, you haven't done the anatomy part yet, so you'll do the physiology in the next part. Those of you in the Wednesday will do, no, wrong, I messed that up, haven't I? Those of you in Monday's lab will do the physiology, and those of you, am I saying this correct? And those of you in the other lab will still has to do it. Who hasn't done the anatomy yet?
Okay.
Monday has not done the anatomy yet. Okay. So Monday does the anatomy, Wednesday we'll do the physiology, and then the following Monday you'll get to do the physiology. We'll actually do some urinalysis, which is kind of interesting, and we'll also do we'll actually look at some of the urine. You'll do some centrifugation of that and look at some of the solids and crystals and things like that as well. Okay, so urinary system maintains homeostasis by regulating the volume and composition of the blood. You know, that is one of the definite functions of the urinary excretory system. It concentrates urine to 855 to 1355 milliosmol per liter. It excretes solutes, especially metabolic waste, so they do make it through into the tubules. You know, they are small enough, and we are pushing them through in hydrostatic pressure. But this shows you generally what we see in the blood versus in the urine, over on the right side there. So you can see which things do make it through and which things don't by looking at those numbers. You know, obviously sodium can move over easily, potassium can move over easily, glucose not so much, lipids not so much, proteins not. You don't want to see, generally you hope not to see any of that in your urine. And then of course the nitrogenous waste you're certainly going to see in higher amounts. Okay, urea, that's the most abundant organic waste you're going to see. It's a byproduct of amino acid breakdown. And remember, amino acids, we call them that because they have an NH group, and you remove that NH group, we do convert that to urea, which is less dangerous. If we held on to the ammonia, that could be a problem, right? Creatinine, that's a byproduct of creatine phosphate breakdown in the muscles. Use that as an energy source. And then uric acid, it's formed during recycling of nitrogenous bases of RNA. Sometimes we have a little bit of trouble if we concentrate that a lot and we have uric acid crystals forming. So 3 processes in urine formation. We do have filtration at the very beginning. So blood pressure does force water and solutes across the membrane of the glomerular capillaries in the capsular space and then into the tubules. But again, they have to be of a certain characteristic to make it through. But we also still have reabsorption that occurs in the urine making process. Transport of water and solutes from the tubular fluid across the tubular epithelium into the peritubular fluid. So now we're actually doing reabsorption out of the tubules. And of course, a lot of this is going to be dependent on the hormones that are around at the time, like ADH. You remember that from endocrine system? We'll talk more about that. And then you have secretion occurring as well, as we already said. You're actually going to transport some solutes from the peritubular fluid, which are around the tubes, into the tubules. So we've got stuff coming in the tubules and going out of the tubules. So those are the 3 basic processes occurring in that entire nephron, all along it. Okay, so let's talk about each segment separately. There, again, are the 3 processes when making urine: filtration, reabsorption, secretion. So remember that. Filtration occurs only in the renal corpuscle. That's the only place there's any filtration, which I was alluding to earlier. Balance between the reabsorption and secretion is going to vary in the remaining nephron segments. You know, you're going to find it really interesting that at points in the segment, in points of the segments of the nephron loop, we'll pull things out, and then in the next part, we'll actually basically put them back in. It almost seems nonsensical, but there's real reasons for doing that, and we'll talk about that. Regulation of the final volume and solute concentration is from the interaction between the collecting system and the nephron loops. Okay, so this graphic kind of summarizes a lot of the things that are going on. As you can see at the very beginning, we have the production of the filtrate that goes into the initial tubule. At the proximal convoluted tubule, we have reabsorption of water, ions, and all the organic nutrients. So they come back out. So again, even though we just put it into the tubule, now we're going to take some of that back out. And then we're going to go down here into the descending thin limb. We have more reabsorption of water we're going to pull out. As we go into the ascending limb, which is thicker, we have reabsorption of sodium and chloride, which are being pulled out. Get here to the distal convoluted tubule. We have secretion of ions, acids, drugs, toxins, which come back in. Okay, so this is the point at which we really are getting rid of some of the waste that we typically think of getting rid of in the urine that we need to get rid of. But, and this is one of the things I was saying, that part though isn't a filtration process, right? It's getting into the urine in a different way. Variable reabsorption of water, sodium ions, and calcium ions, and that is under hormonal control, which we'll talk more about. Then you get to the collecting duct. Different amounts of reabsorption of water still, reabsorption or secretion of sodium, potassium, hydrogen, bicarbonate, depending on what is needed. It, you know, depends on what the pH of the blood is at the point, and urine, and again hormones and how much sodium is in your system. Okay, so this chart goes over more specifics of some of that. At the renal corpuscle, that is where you have filtration of the blood. You get about 180 liters per day of the filtrate. That's kind of similar to blood plasma, but it doesn't have plasma proteins in it, because those do not get through. The specific functions, water and inorganic and organic solutes from plasma are basically filtered. We retain plasma proteins in blood cells. Once we get to the proximal convoluted tubule, we reabsorb 60 to 70% of the water, 99 to 100% of the organic substrates, 60 to 70% of the sodium and chloride ions in the original filtrate we're also reabsorbing back out. And it's funny, we just put it in there, we're going to take most of it back out at that point. So, but we do have active reabsorption, specifically of glucose, other simple sugars, amino acids, vitamins, ions, like sodium, potassium, calcium, magnesium, phosphate, bicarbonate. We have some passive reabsorption of urea, chloride ions, lipid-soluble materials, water. But we do put some things into it at this point, the proximal convoluted tubule. So we're secreting hydrogen ions, ammonium ions, creatinine, drugs, and toxins. And that's at that proximal convoluted tubule. As we move to the nephron loop, we have reabsorption of 25% of the water, 20 to 25% of the sodium and chloride. So again, that's being taken back out of the tubes. So we're creating a concentration gradient now in the renal medulla, because that's where we are at this point with the nephron loop. And we have reabsorption of sodium and chloride ions in water. As we move to the distal convoluted tubule, reabsorption of different amounts of water, about 5%, under antidiuretic hormone control at this point, ADH, and different amounts of sodium ions under aldosterone stimulation. So those two hormones are going to be very important here. So specifically, reabsorption, we have sodium and chloride ions, sodium ions, calcium ions, water coming out of the tubes, but we're going to add back in secretion, hydrogen ions, ammonium ions, creatinine, drugs, and toxins. And as we move to the collecting duct at the very end of the process, We have reabsorption of different amounts of water. Again, at this level, it's under antidiuretic hormone stimulation. And we have different amounts of sodium ions that are under aldosterone stimulation. So do remember this though, at this two level, the distal convoluted tubule and the collecting duct, this is where ADH and aldosterone have their impacts. Okay, this is where those two hormones have their impacts. And more specifically, at the collecting duct, we have reabsorption of sodium ions by carbonate ions and water, okay, pulling them out of the tubules, but we're adding back in potassium and hydrogen ions. Okay, and then the peritubular capillaries, which are all the little capillaries that surround the tubules. We have redistribution of water and solutes that are reabsorbed in the renal cortex. We have return of the water and solutes from the peritubular fluid to the general circulation. And the vasa recta, which are in the juxtamedullary nephrons. We have redistribution of water, but also solutes are reabsorbed in the renal medulla, stabilization of the concentration gradient. And we have return of the water and solutes from the peritubular fluid to the general circulation. Okay, let's look more detail at the renal corpuscle, or the glomerulus, and the glomerular capsule around it. So here we have the afferent arteriole where we're bringing in the blood. That's where filtration occurs. The efferent arteriole, this delivers blood to the peritubular capillaries. Remember, it's going to wind back around and go all around the tubules. A smaller diameter than the afferent. So this tube is smaller than this tube. And the reason why is it increases the blood pressure in the glomerulus so that it helps in pushing fluid through. Okay, the capsular space between the layers of the glomerular capsule, that's here, and the juxtaglomerular complex, this will secrete, and that's shown there, this will secrete renin when the glomerular blood pressure decreases. And we've talked about renin before. We'll talk more about it. Okay, intraglomerular mesangial cells. These are supporting cells. They're between the adjacent glomerular capillaries. They control the capillary diameter and rate of blood flow. So they have a big impact on the pressure that's coming into the glomerulus. So that's some of the regulatory mechanisms. The glomerular capsule itself, that's what surrounds the renal corpuscle. Covers the glomerular capillaries. And the parietal layer is what forms that outer capsule. Then we have a visceral layer that covers the capillaries. It has podocytes. Very large cells, they have foot processes. They wrap around the glomerular capillaries, and that's shown in the picture. There's gaps between the different pedicels, and those are filtration slits. If we look closer at the filtration membrane that's seen in this picture, we have fenestrated glomerular capillaries that have large diameter pores. Then there's a dense layer that's a specialized basement membrane. And we have filtration slits from the podocytes, which you can see there. Combination of all those layers does keep the plasma proteins from going into the capsular space. So they limit by size what can go through. So again, we're at the glomerulus. Keep that in mind. Okay, so remember we were talking about we can regulate what goes in and out, and we have the efferent capillary arteriole that is smaller than the afferent, so we can build up pressure if we want. Well, we call this glomerular hydrostatic pressure. That's the blood pressure in the glomerular capillaries. It pushes water and solutes out of the plasma into the filtrate. We also have capsular colloid osmotic pressure though. So that means basically the solute concentration inside of the fluid, inside of the glomerulus. And few, if any, plasma proteins actually make it into the capsule space. So we still have, it's like when we're talking about a hypertonic situation that pulls water into it. So you still have to kind of overcome that. So the glomerulus itself has a lot of concentration, let's say solutes in it. So you still have to overcome that kind of a negative pressure trying to pull stuff back into it. Then you have blood colloid osmotic pressure. That's pressure due to the materials in the solution. It tends to draw water out of the filtrate into the plasma, so that's another opposing force to pushing it out. So the capsular hydrostatic pressure also opposes the glomerular hydrostatic pressure. It tends to push water solutes out of the filtrate and into the plasma. So we're saying we still have a certain amount of pressure pushing backwards too that is hydrostatic. The typical kind of pressure as you think of, like barometric, but it results from resistance of the filtrate that's in the nephron. Then you have net filtration pressure. That's the pressure that acts across the glomerular capillaries. So that involves all those things we just talked about. The sum of the hydrostatic pressures and the colloid osmotic pressure. Average pressure forcing the water and dissolved substances out of the glomerular capillaries and into the capsular space. So generally you hope that the net filtration pressure is positive so that you can actually push stuff across the glomerulus into the tubules. You hope all those other pressures that oppose the hydrostatic pressure aren't strong enough to hold it back, for the most part, depending on the situation. I mean, sometimes you don't, the body doesn't need to be producing urine under certain situations, maybe. Okay, so this just shows all those different potential opposing forces. So we're trying to push the fluid this way to the right into the tubule across the glomerulus. But again, you do have pressures that are opposing it. But generally, you have enough hydrostatic pressure pushing that you're going to get stuff over. Okay. Two interacting levels control help stabilize the glomerular filtration rate. We have autoregulation. That means that happens right there at the glomerulus, local level. And then central regulation that now involves your endocrine system. That's initiated by the kidneys. But you also have a neural component. The nervous system involves sympathetic division of the autonomic nervous system. Okay, so let's say we have homeostasis disturbed by decreasing blood flow to the kidneys. So we have decreasing blood flow to the kidneys. This causes us to have decreased filtration pressure going in, therefore decreased filtrate and urine production. This is going to cause contraction of the intraglomerular mesangial cells, constriction of the efferent arterioles, and dilation of the afferent arterioles. So it's going to open up the tubes coming into it to try to increase more coming in, and it's going to restrict what's going out of the glomerulus to increase the pressure. So it's going to try to do the opposite here, right? If you have decreasing blood flow, it's going to try to increase the pressure inside. So now we have increased glomerular blood pressure as a result of all of that, and that restores blood flow and pressure to the kidneys. So if autoregulation doesn't work, then central regulation kicks in. The juxtaglomerular complex kicks in. And it initiates the renin-angiotensin-aldosterone system now, or the RAS system. We mentioned it once before in the endocrine system, though we didn't get into a lot of detail on it. And it gets pretty complex. So if we don't increase the pressure coming in to get the fluid across into the tubules, and we need to increase that pressure still. That other thing didn't work. Now the juxtaglomerular complex is going to release renin into the bloodstream. That triggers formation of angiotensin 1, activated to angiotensin 2, and by an enzyme called ACE in the capillaries of the lungs. Angiotensin 2 constricts the peripheral arterioles and further constricts the efferent arterioles. So that's going to help increase pressure in the glomerulus. Well, I'll continue this direction too. Then we have increased glomerular blood pressure as a result of that. We also have increased systemic blood pressure. Okay, now let's go the other direction. Angiotensin 2 also triggers increased aldosterone secretion by your adrenal glands. Aldosterone, as you might recall, increases sodium retention in your body. And that causes a lot of things. Increased fluid consumption. And keep in mind there's a couple of other things going on at the same time, because now you have a neural response that kicks in because of the renin. And its impact is in the autonomic nervous system, and it increases stimulation of your thirst centers to make you more thirsty, to increase your fluid consumption, okay? And that's a part of the aldosterone increase in sodium retention too. And also nervous system control, increased ADH production, which increases your fluid retention. And keep in mind, whenever you increase your fluid retention, that means you have more fluid pumping through your blood vessels, and that increases your overall blood pressure. And therefore, you're going to have more fluid overall going into your kidneys eventually. Increased sympathetic motor tone also causes constriction of your systemic veins, increased cardiac output from your heart. And together, angiotensin 2 and the sympathetic activation stimulate the peripheral vasoconstriction, so some of the blood vessels constrict. That increases overall pressure as well. In the end, you have increased blood volume, increased systemic blood pressure, and look, finally, increased glomerular blood pressure. All this to just get the pressure back up in the kidneys so you can push fluid over to make urine. But it's important, because if it doesn't happen, you're going to have a lot of things backing up and causing major homeostatic problems. And kidney shutdown is one of the worst things that can happen. It's often, I think I mentioned last time, like that final thing that if somebody's on their way out, you know that they're probably not going to make it. I know often in our family, when we've been at the hospital, that's one of the last signs, right? Kidneys are shutting down. Okay. Reabsorption predominates along the proximal convoluted tubule. So now we're going to get away from the glomerulus, and we're going to talk more about the proximal convoluted tubule. So we have reabsorption in the proximal convoluted tubule. Okay, it predominates. Remember, reabsorption doesn't mean we're bringing more stuff into the tubule. It means we're taking stuff out of the tubule and bringing it back into the space around the tubules and potentially into the capillaries around it. So greater than 99% of the glucose, amino acids, and other organic nutrients are reabsorbed. Sodium, potassium, bicarbonate, magnesium, phosphate, sulfate, water, about 108 liters each day. And when you do this, when you're doing all this reabsorption, your solute concentration of your tubular fluid is going to decrease. And water moves into the peritubular fluid. Okay, so this graphic shows what's happening at the proximal convoluted tubule. And again, this is the tube. That's the tube in blue there on the right. Red are those capillaries. So what's in the tube is basically urine. So notice in blue we're pulling stuff out and taking them to the capillaries. In red we're secreting and putting stuff in, but obviously, as it said, reabsorption is predominant here at the proximal convoluted tubule. And you see all the stuff we're pulling out. Okay, now we're going to move to the distal convoluted tubule. Reabsorption and secretion are linked along the distal convoluted tubule. Movement of water and solutes out of the peritubular fluid into the tubular fluid. So now we're moving stuff from around the tubes back into the tube. Only 15 to 20% of the initial filtrate volume reaches the distal convoluted tubule. Of all the stuff we pushed into the tubes to start with, only 15 to 20% even remains by the time we get to that point. And a combination of all of the reabsorption and secretion at the distal convoluted tubule is going to change all the solute concentrations. Sodium ions are going to be reabsorbed, so pulled out, in exchange for potassium ions that we're going to pump back in. And this is being stimulated by aldosterone. That's what's causing us to secrete potassium back into the urine at the distal convoluted tubule. Hydrogen ions are secreted in exchange for sodium ions. So we're pushing more hydrogen ions into it, and we're pulling sodium ions out. And the reason why we're doing this, we're going to increase pH of your body fluids. Increased pH, remember, means you're going to make it basic. You're going to go above 7. So we're going to take the hydrogen ions, and that's basically what causes acidity, right? The more hydrogen ions you have, the more acidic, or below 7. So if your body fluids are getting too acidic, we'll pump more hydrogen ions into the urine. Carrier proteins also secrete toxins or drugs. So at this point in the distal convoluted tubule, if we have extracted some toxins or drugs out of your system, we're going to put them into the urine at this point. So again, this is the graphic showing all of what we just talked about. We're at the distal convoluted tubule. Notice we've got things going both directions. We're pulling out sodium, but we're putting in potassium, hydrogen ions, toxins, and drugs. That's at the distal convoluted tubule. Okay, exchange between the limbs of the nephron create an osmotic concentration gradient in the renal medulla. Okay, so where is the renal medulla? Keep it all in perspective. Keep the picture in our head. Where is it?
The innermost part of the kidneys.
Yeah, the innermost part, exactly. Cortex is the outer, medulla is more inner. It's where the pyramids are. Okay? So we're going to create an osmotic concentration gradient in the medulla. That means we're going to have real differences in solute concentrations between different parts of it. Okay, so we have countercurrent multiplication. The thin descending limb and the thick ascending limb, they're close to each other, right? I mean, every time we show a picture, they're just in the U. One's on one side, one's on the other. And they're separated by a peritubular fluid. An exchange between those two limbs we call countercurrent multiplication. It's countercurrent because fluids moving in opposite directions are occurring. Multiplication because the effect increases as you have more fluid movement. Anyway, this creates a concentration gradient in the renal medulla, but that's what enables us to have really highly concentrated urine. Because by having concentrated material or solutes around the tubules, we can pull a lot of the water out, right? And by pulling a lot of the water out, you concentrate what's inside of the tubules. Okay. So again, remember, salt draws water, right? So it's not just salt we have around the tubules, it's other things, but we're just drawing water out of them. And that creates the ability to have concentrated urine when we are pulling water out, and that's what's shown in blue. So we're pulling water out. Over here, we're pulling more solute out. But in what they were just saying, countercurrent multiplication, they're working together. Okay, we're increasing the concentration around the tubes by increasing the solute out here. But by increasing the solute out here, it also helps us to pull more water out. Now, let's look at the thick ascending limb. This is the one that's going to go back up right before we get to the descending, right before we get to the distal convoluted tubule. At this point, we actively transport sodium and chloride out of the tubular fluid. Out of the tubular fluid, sodium and chloride. That means we're bringing it out of the tubes, right? That's what you see in blue there. Again, there's the tubes. That's where the urine is. It's impermeable to water. It's very thick, so water can't get in or out there. The tubular fluid solute concentration then decreases because we're able to pull out sodium, potassium, and chloride, but we can't pull out any more water at this point. So as you pull out a lot of solute, you're decreasing the concentration of solute inside the tube. The peritubular fluid concentration, though, increases, right? Because you see all the chloride, potassium, and sodium here. So we decrease concentration here, we increase it here. So the osmotic concentration of the peritubular fluid out here, in here, there we go, is increased from the activity of the thick ascending limb. Peritubular, they're calling that peritubular, okay. And then the thick, thin descending limb is permeable to water, which is over here. But it's impermeable to solutes. So this is permeable to solutes but impermeable to water. This is permeable to water but impermeable to solutes. So you see they're opposite in what they can do. So water moves from the tubular fluid in the peritubular fluid by osmosis, and tubular fluid solute concentration increases. Notice how the number gets larger as we move around. We start at 300, 600, 900, 1200, a little change here, and then finally we get back to 3 and 100. But it increases from there to the bottom of the tube in the descending loop. But going down in the surrounding fluid, we increase. So they're talking about going from top to bottom. Okay, the concentration of the urine, water is reabsorbed along the distal convoluted tubule and the collecting duct. So there's the distal convoluted tubule. They're not showing it very convoluted, but they're just showing you the area. And there's your collecting duct. So water now is being reabsorbed along distal convoluted and collecting duct. So we're pulling out more water, and that's shown here. And therefore we are now increasing the concentration of solutes even more in the urine, specifically urea. And urea on this picture is in orange, as you can see. Tubular fluid reaching the papillary duct has a typical urea concentration about 450 milliosmolar per liter, which is pretty high. Okay, now overall, the volume and concentrations of the urine are hormonally controlled. We have something called obligatory water reabsorption that occurs in locations where the water movement cannot be prevented. So the proximal convoluted tubule and the descending limb of the nephron, which are shown here highlighted. So there's the proximal convoluted tubule, and there's the descending limb of the nephron. So the rate cannot be adjusted. It recovers 85% of the filtrate. So water just moves out. We take a lot of the water back up at that point. Facultative water reabsorption. This occurs in the distal convoluted tubule and the collecting duct. Here we have more precise control of water reabsorption. It adjusts the urine volume by reabsorbing part or all the remaining 15% of the filtrate volume. And again, remember, this is where ADH and aldosterone has impacts. So again, in the earlier part, we don't have much control of the water. In the end part, we have more control of the water. So if we don't have antidiuretic hormone around, so this is just looking at scenario, urine volume without antidiuretic hormone. No water is reabsorbed in the distal convoluted tubule and collecting duct. And therefore no facultative water reabsorption occurs. Okay, so if you don't have antidiuretic hormone around, no water is going to be reabsorbed back out of the tubule. So what does that mean for the amount of water that's going to be in the urine at the end? So if you don't have a lot of reabsorption, what?
You're going to be dehydrated.
Well, no, I mean you're not pulling a lot more water back out of it, so most of it's
Just
staying
coming
in.
back out.
Most of it's staying in. Okay, so if you don't have, so urine volume without ADH, no water is being reabsorbed out of the tubule. Okay. Now, if we have ADH, the ADH allows water channels to form. Aquaporins appear in the apical plasma membrane of the distal convoluted tubule and the collecting duct. Water permeability of the last tubular segments will increase, and this increases water reabsorption. So now, if we do have antidiuretic hormone, we can pull water back out of the tubule. And now we're going to have a small volume of concentrated urine at the end of it. Antidiuretic. So if you take a diuretic, it makes you release a lot more water, right? But if it's an antidiuretic, it's the opposite. You can't release as much water. So when ADH is kicked in, your body reabsorbs more water. And this is basically what happens if you have a lot of sodium intake, and you heard of people say I've got water retention. I must have, because I ate a lot of salt last night, and that's what's going on. Oops. Okay, so normal urine. Normal volume is about 1,200 milliliters per day. Has an osmotic concentration of 1,000 milliosmolar per liter. The values do differ from person to person, from day to day. The kidneys alter their function to maintain your homeostasis because you're eating differently, you have different activity. Maybe you were really hot on a particular day and you sweated it out. Renal function is an integrative process involving filtration, reabsorption, and secretion. Okay, so that's kind of a summary statement, really. At the renal corpuscle, filtrate has the same osmotic composition as plasma. It's right there at the renal corpuscle. Same composition as plasma, except, again, for the plasma proteins. Okay, because they don't make it over. Proximal convoluted tubule ions and organic nutrients are removed from the tubular fluid. Water follows by osmosis. Remember, this is where you lose a lot of that water. That's your obligatory water loss, water reabsorption. That's what I meant, reabsorption. I'm thinking of loss out of the tube. This reduces tubular fluid volume, but keeps tubular fluid and peritubular fluid isotonic. So your proximal convoluted tubule in the descending limb of the nephron loop, here you have that obligatory water reabsorption I just mentioned. It concentrates the tubular fluid. So as you lose more water out of the tubes, in the tube it's more concentrated now because you have more solute. So that's what's showing there. Notice how this number in the tube increases. That's the concentration as we pull out more water. At the ascending limb, we actively transport sodium and chloride out of the tubule because it's impermeable to water, as we said. Remember, that's a part of that counter current multiplier. So that increases the solute concentration out of the tube, which helps to pull out more water at that descending limb. It lowers the osmotic concentration of the tubular fluid because you're getting rid of sodium and chloride. At the distal convoluted tubule collecting system, they make certain adjustments, so you have reabsorption and secretion of the solutes. And this is hormonally controlled water reabsorption. Remember, I told you at the distal convoluted tubule and the collecting duct is where ADH and aldosterone have their impact. Remember that. Okay, the vasa recta. This is the capillary network around the juxtamedullary nephrons. It absorbs solutes and water from the tubules into the systemic circuit, and it maintains a concentration gradient in the medulla. So let's talk about what happens in some of these cases where the kidneys are not working properly. So renal failure. This occurs when the kidneys cannot filter waste from the blood and can no longer maintain homeostasis. It impairs all the systems in the body, and you get a decrease in urine production. So that's one of the first things you start noticing. Again, like I said, if we know somebody's probably not going to make it, we start looking for those signs. They start not producing urine. We have a rising blood pressure. Anemia occurs from the decline in the erythropoietin production. That's the hormone that increases blood cell formation, red blood cell formation. Central nervous system problems develop, so sleeplessness, seizures, delirium, and coma. In chronic renal failure, the kidney function deteriorates slowly. Associated problems then accumulate, but we can slow the progression, but the condition is not reversible. It's chronic. Management, restricted water, salt, protein intake. We can reduce strain on the urinary system if we minimize the volume of the urine produced and the amount of the nitrogenous waste that are generated. Acidosis can occur. It can be countered by ingesting bicarbonate ions, like from baking soda. Okay, in acute renal failure, kidney function deteriorates very quickly in just a few days. It can be impaired for weeks. You have a sudden slowing or stopping of the filtration. That can be caused by exposure to toxic drugs, renal ischemia, urinary obstruction, trauma. Also, allergic responses to antibiotics, anesthetics, if you're sensitized. A recovery of partial or complete function can occur if the person survives the initial incident. Survival rate about 50% with supportive treatment. So acute renal failure is extremely serious. There is dialysis. Passive diffusion across selectively permeable membrane. Hemodialysis uses artificial membranes. We can regulate the composition of blood doing this with the dialysis machine. Membrane pores do allow diffusion of the ions, nutrients, and organic waste, but not the plasma proteins. The dialysis fluid will contain specific concentrations of solutes. It's run on the other side of the membrane. And then we have shunts, which are silicone rubber tubes that connect the blood vessels with the dialysis machine. And here's a comparison of what plasma looks like compared to dialysis fluid. This is a diagram of that operation. To treat for renal failure, dialysis will relieve some of the symptoms, but it's not a cure. Kidney transplant's the only real cure. And survival rate's more than 90% at 2 years after a transplant, so that's pretty good. If it's a close relative donor, much more successful. People still have to take immunosuppressive drugs, though, to reduce the rejection of a transplant, just like in all transplants. Let's carry this out a little bit further then. Because we've been talking all about the kidneys, let's look at the rest of the urinary tract. The urinary tract transports, stores, and eliminates urine. So now we got the ureters, the urinary bladder, the urethra, and we can use a pyelogram to look at this. It's an X-ray image of the urinary tract. We use a radiopaque dye. So the ureters, of course, join the kidneys to the bladder, paired muscular tubes. They're retroperitoneal. They're attached to the posterior abdominal wall. The urinary bladder is a hollow muscular organ, holds up to 1 liter of urine, and then the urethra, of course, exits from the bladder. The urethra extends from the neck of the urinary bladder to the exterior, and there are different lengths in males and females. The male urethra is longer, transports semen as well as urine. So that's another difference between male and female. In addition to be longer, it also has another function. The urinary bladder is filled by the ureters and drained by the urethra. Dimensions are different depending on how much urine's in there, if it's state of distension. Posterior, inferior, and anterior surfaces outside the peritoneal cavity, they're anchored to the pelvic and pubic bones by the supporting ligaments. You have a lateral umbilical ligament, or ligaments, sorry, that really were vestiges of the umbilical arteries. And then you have a middle umbilical ligament. If we look inside of a bladder, we see rugae, which are folds in the bladder lining. Okay, we also call those folds in the stomach rugae, right? The ureteric orifices are slit-like shape, have a slit-like shape that helps prevent backflow of the urine into the ureters when the bladder contracts. The ureters penetrate the posterior bladder wall at an oblique angle. The trigon is a triangular area that's bounded by the ureteral openings here at the bottom and the entrance to the urethra. At the neck of the urinary bladder, this surrounds the urethral opening. It has a muscular internal urethral sphincter. This is under involuntary control, the smooth muscle. And here. Then you have an external urethral sphincter, shown at the very bottom. It's under voluntary control. It has to be voluntarily relaxed to permit urination. If we look at the ureter in cross-section, we do see transitional epithelium, just like we see with the bladder. So the bladder and ureters do have transitional epithelium. Remember, it's a little bit different. And it surrounds the lamina propria. We have middle muscular layer. These are bands of smooth muscle. They do allow peristaltic movement. And we have an outer connective tissue layer. If we look at the wall of the urinary bladder, we have mucosa, submucosa, and muscularis layers. Again, you have a transitional epithelium. Mucosa. The muscularis layer has 3 layers, an inner longitudinal, and a circular, and an outer longitudinal layer. And all together, they form the detrusor muscle. Again, that's the urinary bladder. The urethra, this is lined with stratified epithelium that varies by location. Transitional epithelium at the neck, stratified columnar at the midpoint, stratified squamous at the external urethral orifice. We have a thick elastic lamina propria in the wall of the urethra, longitudinal folds in the mucous membrane. We have mucus secreting cells in the epithelial pockets. Okay, so when you gotta go, this is micturition, fancy word, I guess, for having to go. The micturition reflex, it coordinates the process of urination, involves local reflex pathways, also a central pathway through the cerebral cortex. So first, the urine storage reflex, we have stretch receptors in the urinary bladder. They distort as it fills. Then afferent impulses stimulate the sympathetic stimulation to the detrusor. This stimulates the contraction of the internal urethral sphincter. We have the pontine storage center. It decreases the parasympathetic activity and increases the somatic motor nerve activity of the external urethral sphincter. Then we have the urine voiding reflex through the pontine micturition center. The interneuron relays sensation of the bladder fullness to your thalamus. You have projection fibers that relay the information to the cerebral cortex. Then voluntary relaxation of the external urethral sphincter occurs, which causes relaxation of the internal urethral sphincter. And since the pressure now is already increased, relaxing of that sphincter leads to urination. You probably didn't know that it was so complex. Okay, signs of urinary disorders, change in volume, appearance of urine, polyuria, so when you have excessive urine production. This may come from hormonal or metabolic problems, maybe diabetes or glomerulonephritis, or oliguria, this is reduced urine production. Anuria, this is severely reduced urine production, 0 to 50 mils per day. Oliguria and anuria indicate serious kidney problems, potential renal failure. Also, change in frequency can mean something. If you have increased urgency or frequency, it might be irritation of the lining of the ureter or the urinary bladder. And then incontinence is another problem, or the inability to control urination voluntarily. It could be periodic involuntary leakage, that's called stress incontinence, or inability to delay urination, or urge incontinence, or continual trickle of urine from the full bladder, or overflow incontinence. Urinary retention, this is initially a normal renal function, but urination does not occur, and in males can commonly result from enlarged prostate. Okay, pain in the superior pubic region could be associated with urinary bladder disorders. Pain in the superior lumbar region, or the flank that radiates to the right or left upper quadrants, could be associated with kidney infections or pyelonephritis, or associated with kidney stones, renal calculi. Dysuria, this is painful or difficult urination, which occurs with cystitis or urethritis or urinary obstructions. It could also be enlarged prostate in males. Edema or swelling, this can occur when the renal disorder leads to proteinuria or protein in the urine. Also facial swelling, especially around the eyes, can be common as a result of urinary system disorders. Fever commonly develops when the urinary system is infected. Cystitis is a bladder infection, usually low-grade fever. Pyelonephritis is a kidney infection and can produce very high fevers. All right. As you have time, especially go back through the function of the kidney and nephrons, because it can be very confusing. But if you go through it a few times, it really does start making sense about where solutes are taken up or given off, and where water is being reabsorbed or being put back in. So do read through that a few times. Also look at the Khan Academy or the crash course A and B stuff if you want to get another description of what happened. So probably the best thing you can do is just spend as much time as possible going through the processes.